This is the third part of the introductory lecture on myopia and its development. Little bit introduction before we get on to the second chapter of how myopia progresses. This is just a small introduction to know more about myopia and its progression. So we have understood by now that myopia is progressing and it is going to progress in coming years. And the progression is multifactorial. There is a theory between nature and nurture, and we will see some slides on how it is the genetic factors which are responsible and how it is the nurture factors or environmental factors which are responsible. Currently, the understanding is that it is basically the near work, the outdoor work, dopamine release, maybe red light or blue light. So there have been contrasting views with some of the groups claiming that it is the blue light which is quite useful, and then other instruments, devices. There is a separate chapter talk on ortho K and red light therapy, which are not currently into the market in India, but soon it seems that they would be one of the important reasons, one of the important things which will be in the market. Now, basically, when you think of myopia, it being multifactorial, to begin with, it is the genetic aspect which has to be seen. And on the top of genetics, so genetic aspect can be divided into two parts. One, that the patient is predisposed towards myopia, predisposed towards development of myopia. There are factors, there are genes which are responsible for myopia. There are syndromic genes which are associated with myopia. And then on the top of it, there is a genetic pool which is susceptible to environmental challenges like near work and outdoor timing. So not all the children who sit indoors, not all the children who do near work are prone towards myopic progression or would go for myopia, but there are certain genes which are responsible for this particular environmental effect, and this is what gets affected. And there are other genetic pools which are directly responsible for myopia. So myopia indeed is multifactorial, and there have been more than 200 genetic loci which have been identified as as associations, which have associations with myopia. We would also take this up when we will be talking about the genetic factors being responsible for myopia. There have been multiple genes which have been implicated in retinal cascade signaling. There have been a consortium for refractive error and myopia, and they did a genome-wide association studies, and they found that there was 10 times increase in prevalence of myopia as per the prevalence of myopia depending on the genetic pool. So this has already been taken. So the risk of myopia definitely increases if one of the parents is myopic, and it increases almost twofolds if one of the parents is myopic, and if both the parents are myopic, it increases by fivefold. And then there have been multiple environmental details or environmental factors which are responsible for myopia progression. Time spent in outdoor activities in relation to myopia prevention and control. Outdoor activities, it reduces the prevalence of myopia in children. Sleep duration, bedtime, myopia progression, and objectively measured near work, outdoor exposure, and myopia, everything implicating the fact that it is indeed the near work, with some uh, school of thought saying that it is the near work which is more important than outdoor exposure, versus other school of thought which says that it is the outdoor exposure which is more responsible. Nevertheless, both near work, outdoor exposure, both are important when it comes to myopia progression and myopia. And these are some of the articles which are there, and I'm pretty sure that there are more and more articles which are coming up. The most important point here is to understand that it is very difficult to measure, objectively measure near work, objectively measure outdoor exposure, and to objectively measure what is the amount of UV light which is going inside the body, inside the eye, whether they are sitting in the shade. So there have been some work done by Pawan Varkicharla from LV Prasad, where they have tried to see if you sit in shade, whether it is similar to sitting in non-shady areas. And they found that when you sit in shade, even in sun, the amount of intensity of light is as good as indoor sitting, and it is not huge. Whereas there are other groups where they have found that, even if you sit outdoors, you're not doing near work, and that is better. So there is a conflicting view. This is a good timeline where they have suggested that myopia prevalence is on rise since 80s, and it has risen very quickly following the introduction of smartphone, following the introduction of near work due to smartphone. And the smartphone penetration was very minimal in 2014, and now it has been huge smartphone penetration. And so then that is how the progression of prevalence of myopia has increased. So all this is about the prevalence of myopia, which has increased. For us, we should not forget that we are discussing here about the progression of myopia and not just the prevalence of myopia. For prevalence of myopia, we should uh, sit together and talk more about pre-myopia, and once the myopia sets in, we have to think about progression of myopia. So there have been a lot of articles, especially from smaller countries like Singapore, in Denmark. They have done activities where they have found that there is a direct correlation between height, and as the height increases, myopia progresses. And there have been a direct correlation with physical activity and myopia. And they have tried to see a correlation between growth spurt that occurs uh, between prepubertal and pubertal area. So the key messages from all these articles is that if parents have myopia, kids are more likely to have it. Preterm children have a risk of myopia too, but that is because of the crowded anterior segment and not truly about axial myopia. Outdoor activities do make a difference in the growth of eyeball and myopic progression. So outdoor activity really holds important. Near work and amount of light does result in myopic progression. Height increase directly correlates with the growth of size of eyeball. And it is important to note here with what they found in Singapore study was that 2 years before the height spurt occurs, eyeball size starts increasing. So before they actually have a physical growth in terms of height, you will see that there's an increase in myopic spurt, more seen in girls, mainly because they tried to implicate that girls reduced the outdoor activity and physical activity, and that probably led to a higher spurt in the myopia groups. So, genetic risk scores and environmental risk scores together would make the child susceptible to myopia and progression, and it is basically the environmental risk factors on the top of already genetical susceptibility in myopia would lead to a higher progression in myopia. So does vitamin D has any role in myopia? So they did found that um, vitamin D deficiency was seen in bulk of the patients in myopia, but I think when you do a vitamin D test, even in otherwise healthy children, or if even if they don't have myopia, would also, at least in India, would have a vitamin D deficiency. And so there have been a lot of articles, and there have been meta-analysis where they feel that it is not really about vitamin D having any role in influencing the growth of eyeball or creating myopia, but it is more about spending the time outdoors, which reduces the vitamin D. Nevertheless, one can easily use vitamin D supplements, but I think we should not really think about vitamin D creating a barrier to the progression of myopia. There have been some work where they suggest that the release of dopamine is there because of vitamin D, and that is what protects against myopia. So yes, there has been some anecdotal evidence, but not a great evidence-based issue that vitamin D does has serious role in the control of myopic progression. And this is about the complications of myopia. As ophthalmologists, bulk of us know what can lead to an uncontrolled myopia, and we all know that myopic maculopathy is vision threatening and sight threatening, associated with choroidal neovascular membrane, staphyloma, retinal hole, peripheral detachment, and peripheral retinal degenerations are very common in myopia. And so once we are planning to set up a myopia control clinic, and I think we will take it in that chapter, that we have to also think about peripheral retinal degeneration and how to diagnose and how to see them, whether to get a wide field camera to be able to detect it in the myopia control clinic, or we should also do a indirect ophthalmoscope just to be sure that there are no peripheral retinal degenerations. As we move on to more and more myopic practice, we have to make a habit of seeing the periphery. Other complications may be at a later age group, primary open angle glaucoma, earlier nuclear sclerosis, and posterior subcapsular cataract. And obviously, they will have an increased risk of surgical complications owing to high myopia and owing to peripheral retinal degeneration. So, these are two key risk factors of how myopia progresses axially. And I think this would be part of the next chapter as to how myopia progresses and what are the risk factors. So there have been both in terms of biological mechanism of atropine and how does it control myopia progression, near work, dopamine release, and genetic factors. So that is regarding that finishes the chapter on the epidemiological aspects of myopia and what are the complications which are associated with myopia. Thank you so much. Looking forward to see you on the Zoom meeting tomorrow. Good night.